A very good afternoon to everyone. On behalf of the Medical Education Unit and the CPC team, it is my proud privilege to welcome you all today for the CPC. And may I request all the dignitaries to kindly grace the dais. Our Honorable Vice Chancellor, Sir, Dr. Dhananjay Agarwal, Sir, please. Our Principal and Controller, Dr. Deepak Maheshwari, Sir. Convener CPC, Dr. Puneet Saxena, Sir. ADP Academics, Dr. Monica Jain, Ma'am. And Senior Professor and Head Department of Orthopedics, Dr. R.C. Bansiwal, sir. To begin with, I would request our respected Principal, sir, to give a floral welcome to our Honorable Vice Chancellor, sir. I would request Convener CPC to give a floral welcome to our Honorable Principal, sir. I would request Dr. Monica Jain, ma'am, to give a floral welcome to our Superintendent of SMS Hospital, Dr. Sushil Bhati, sir. He's also here. Thank you, ma'am. May I now request our Honorable Vice Chancellor, sir, to please bless us with his words of wisdom.
CPC is institution की backbone है, and we are as a student we are learning all the times. All the time I am taking the active participation in the CPC as a student also. Many times I learn rheumatology also and lot of the branches in orthopedic also. Now Dr. Rajkumar will probably have the case on the neoplastic. So I request Dr. Deepak Maheshwari ji and Dr. Bansiwal that at least he should promote the ortho-oncology, because in the beginning as a nephrology we started the nephrology with the 2 beds, 3 beds. No? So around 39 years back we started. So as now we have started organ transplant urology also, or transplant nephrology also. So in the start you can start with the small tables or small things, and then ultimately it will build up within the next 5 years and few years. No? So I request Dr. Bansiwal and Principal Sir also that at least we should encourage these new branches also. Thank you.
Thank you so much, sir. And may I now request our respected Principal, sir, to please address the gathering.
Good morning, esteemed faculty members, VC sir, and my dear students. We are providing health care to all, and we are very good in it, and we are doing exemplary work. But the primary aim of institution is medical education and research. I think there is always a scope for a betterment. All of us should try to do something for this, and this empty chairs are not giving me a good feeling. Please make it sure from the next that everybody should be here. And now I invite Dr. Puneet Saxena sir to proceed with things.
All right. Good afternoon, everybody. So our new Vice Chancellor, Sir Dr. Dhananjay ji, Dr. Deepak Maheshwari ji, our new principal. I can see Dr. Sushil Bhati, who's taken charge of SMS Hospital. Senior members of the faculty, I can see Dr. Shashi Mohan Sharma, Dr. Bansal sir has arrived today. He was ex-HOD Orthopedic Department. All the faculty members and dear students. So as we have been doing CPC, and this is the 9th one in the series, we all know the importance and the interest the last 8 CPCs has generated. and that how we can know about the departments, basically, that what the departments are, what they are doing, what are their future projections here. So it's very correctly said by our principal sir that it's very disheartening to see the empty chairs over here. This is probably once in a month academic activity where all the faculties can at least meet and greet, and they can reach up to the principal sir and the administration also here. So I would request principal sir to pass a circular that the attendance should be mandatory for all faculty members, and the entry of the CPC should be made into the logbooks of all the PGs and to be countersigned by their HODs and the unit heads. So, sir, I am requesting to make it mandatory and to pass an order for the same, right? And we can keep our attendance register as we used to keep in the previous CPCs outside. And everybody, I think they can make working arrangements. People give excuses that they are running OPDs and their theaters, but then everybody can make an working arrangement, and we are always open to adjust the timings. Basically, today it is done on 12 p.m. because we thought that in summers 12 p.m. would be adequate, but probably we are thinking to keep the same time, that is 1 p.m., so that everybody is free from their work by that time. Regarding the SOP of the CPC, we are giving first 15 minutes to know about the department, and that's a very, very nice thing to know about the achievements and the infrastructure and the functionality and faculty of the department, and followed by a case, which should be a case which should be either an unusual case or which should evoke interest of multidisciplinary departments, so that everybody is interested in knowing about it. And it's very good for the PGs especially. Please note that these cases, they are published on the website of the department, so it should be prepared very nicely and adequately, because otherwise it will be dissected by the other colleges and other faculties across India probably. And in the last of the CPC, we are planning to publish and print the compendium of the CPC cases, so we'll require write-ups of all the CPCs. So this is basically an academic parameter of the institute, and will be greatly benefited if this is circulated in the print form after we complete the one full session of the CPCs. So without taking much time now, I will hand over to the team CPC and the orthopedic department to proceed with this CPC. Thank you very much. So next CPC would be held on 20th of June, that is third Thursday, by the Department of Dermatology. And if anybody from the Skin and VT department is here, so please take a note of it. So I don't think there is anybody, we'll inform them. So, thank you.
So today's CPC is by the Department of Orthopedics, a department which believes that every problem in life can be solved by sustained linear traction. So now we have with us HOD and Senior Professor of the department, Dr. R.C. Bansiwal sir, who will give a gist about the department and its achievements. I request Dr. R.C. Bansiwal sir to come onto the stage.
Welcome all of audience, Vice Chancellor sir, Principal sir, Dr. S.M. Sharma sir, Dr. Puneet, Dr. Monica, I highly obliged Dr. Bansal is attending the CPC, his former HOD. I welcome all of you. This CPC is dedicated to Dr. Sudhir, and Sudhir was our senior professor and passed away on 29th April. It is very sad demise. And this patient we are presenting in CPC is also treated under the guidance of Dr. Sudhir. So I will request all of you, please stand and keep silence for 2 minutes. Om Shanti. The Department of Orthopedics was established in 1954-55 and it was established by Dr. P.K. Shetty. The first batch of PG was passed out in 1966 with 3 PG seats. Now the department extended to 4 different hospitals. SMS, other one is County Hospital, Trauma Central, EGSN, separate branch, and Pandit Deen Dayal Upadhyay, Ganaguri Hospital. These are the HODs since beginning to till date. The faculties in the department, the sanction strength is 30, but now working only 19 faculties. It is very scarcity. 6 senior professor, 1 professor, 6 associate professor, 6 assistant professor, and 5 medical officers. 4 our faculties are posted in R&T Medical College, Udaipur, for NMC verification. So I will request Principal Sir and Vice Chancellor Sir to please help to make return of our faculty to the parental department. There are 12 senior residents and 110 junior residents. There are total working in 9 units, 7 units at SMS, 1 in Ganaguri Hospital and 1 in County Hospital. The total number of OPDs in 2023 was 235,407 patients. There are 640 patients per day we are catering in OPD, and also in other specialties of the orthopedics. This is scene of our OPD, fully congested. We have a separate classroom, that is indoor classroom, and nearly about 150 cases benefited per day. In that we are doing reduction of the fractures, plaster applications, and it is done by anesthesia, under anesthesia or without anesthesia. And we are also doing cases of CTV, applying the corrective cast for radial club hands and for congenital contracture of the limbs. We also running many specialty clinics, in which one is hand surgery clinic, and it was established in 1982. Dr. B.K. Pandya sir. It was the first such super specialty clinic in North India performing brachial plexus surgeries, congenital deformities, primary and secondary tendon repairs. And we also doing a leprosy reconstruction surgery camp every year. Other specialty clinics are Elizero Clinic. We were first in North India who started Elizero deformity correction with 3D reconstruction technique using specialized computer generated program by Dr. D.S. Meena in 2004. The latest development in this technique is a new technique is SU frame, and it was included in 2011. Dr. D.S. Meena got the honor of chairing the session of deformity correction in World Congress for Deformity Correction in Miami, USA. He also delivered a lecture in his on his work on 3D deformity correction. We also running a separate oncology clinic, and it is first orthopedic oncology clinic in state and dedicated only for bone and soft tissue cancer patients which are coming in the SMS hospital. We are also having work in the pelvic tumors, which help in resection of the disease part and salvage the limb. In October 2015, the first total femur replacement of the state of patient was done of osteosarcoma. On 30th July 2007, the total elbow replacement with modular tumor and endoprothesis was done for a primary bone tumor. It was started in the SMS and it was the first reported case in the state. On 12th May 2018, a 17-year-old patient with chondrosarcoma, it is a type of bone tumor of calcaneum bone, was treated with radiofrequency ablation and calcaneus cementoplasty. In association with intervention radiology department, the technique involved minimal invasive CT guided procedure, which was first attempted in orthopedic literature. Other special clinics, club food clinic, about 319 children were enrolled in the last year and they were treated in our institute. We are providing full treatment care under one roof from constructive cast, corrective cast to minor operation to maintain the brace on the same floor in the plastron. After correction of the CTV with the application of the DB splint, department has started a dedicated scoliosis clinic in 2024 in Dhanvantri OPD room number 164, and it open every Monday for scoliosis patients. Now comprehensive care for kyphoscoliosis is provided by the department, ranging from brace to complex corrective surgeries. In 2013, we admitted total number of patients is 15,421 patients. The total bed strength in our department is 296. Two bed 2 ICU bed in the SMS ortho ward and 3 beds in surgical ICU in trauma center. These are well equipped with traction units and floor beds. Operation theaters. The total number of surgeries we are doing about 30 to 40 patients per day. The total number of operations done in 2013 are 12,248 in minor and major operations. In Dhanvantri OT, hand surgery OT, in trauma center and in emergency OT. We have high standard fracture tables, 6 image intensifier, 3 at Dhanvantri OT and 3 at trauma center. We also have 2 model OT for arthroplasty surgeries, and we have also arthroscopy system, and regularly we are doing 2 to 3 patients of arthroscopy at our unit, at our department. We also have a well-equipped bone bank, which can be used. The bone can be used for where to required in the tumor and in the big cavities of the bone. We are operating on 15 tables per day, 5 at Dhanvantri OT, 1 hand surgery OT, 5 in trauma center OT, 2 in Ganagori hospital and 2 in county hospital. We have 2 fully functioned 24 hours running OT and 1 hand surgery OT at trauma center, regularly enrolled in the managing cases of in the emergency. We are also doing some complex surgeries which are not doing in the other centers of the Rajasthan. We are doing primary complex revision joint replacement surgeries of hip, knee and shoulder and elbow joint. We are doing arthroscopy and sport injury related surgeries regularly in the department. And we also doing corrective surgeries. We also doing hand and brachial plexus reconstruction surgeries, and also doing bone and tumor, soft tissue tumor surgeries. And Dr. Pankaj Jain and Dr. Rajkumar Aswal regularly doing the bone tumor and soft tissue surgeries. We also doing complex trauma in spine, acetabulum. Pediatric orthopedics. These are the records of our orthopedic department, which is go to Dr. P.K. Shetty, Dr. J. Sharma Sahab, we have held conferences, regular conferences, fellowship, social responsibilities. We are celebrating Bone and Joint Day on 4th August every year. Future planning. Thank you.
Thank you, sir, for telling us all about the magnanimous orthopedics department. So now, without much ado, as Benjamin Franklin said, tell me, I forget, teach me, and I may remember, but involve me, I learn. So is today's CPC by orthopedics department that's going to involve us into a very interesting case. I invite Dr. Ankit Godala, the third year resident, to present the case.
कौन सा है स्लाइड लगा देता हूँ स्लाइड शो हो गया ना अभी Good afternoon. My name is Dr. Ankit Godara and I am third year resident in Department of Orthopedics. So today's case is a case of a 17-year-old male presenting with a swelling at his left leg. Clinical presentation, chief complaints. The patient was a 17-year-old male, construction worker by profession, and he developed a painful, gradually progressive swelling in the middle 1/3 of his left leg over the last 2 months before presentation. The patient also reported some loss of body weight, 3 kg, over previous 2 months. History of present illness, past illness, and family history. The swelling was first noticed 2 months back before presentation. It was gradually progressive in size. Pain was present on walking and at rest both. The pain was also present during night, and it was described moderate in intensity. Pain was relieved somewhat with use of non-steroidal anti-inflammatory drugs. The patient had first sought treatment at a local district hospital, from where he was referred to SMS hospital after initial X-ray. There was no other significant history of diabetes, hypertension, any immunosuppressant drug intake, or any autoimmune disease. He had no other history of other significant family history. General physical examination was conducted, and the patient was found average in build and had normal body proportions. Vitals were recorded, pulse, BP, temperature, all were normal. General physical examination of main principal systems, respiratory, cardiovascular, GI system, and nervous system was conducted, and all were within normal limits. Then the swelling was examined. On inspection, the swelling was present over the anterior, medial, posterior aspect of middle 1/3 of left leg. It was about 10 centimeter into 10 centimeter in size. On palpation, the swelling was tender on touch. Its surface was non-nodular and smooth. Consistency was hard. The swelling was not mobile and adherent to the underlying bone. The margins were well defined but irregular, and the swelling was non-transilluminant. Bilateral inguinal lymph nodes were palpated, and both were not palpable. Ipsilateral side knee joint and ankle joint were assessed for range of motion, and both had normal range of motion. After that, routine battery of investigations were ordered: CBC, ESR, RFT, LFT, electrolyte, serum LDH, serum calcium, and serum phosphate, and all were within normal limits. Now I request Dr. Rajkumar sir to discuss the differential diagnosis of the case.
Thank you, Ankit. Now we have some clinical picture about 17-year-old male, middle 1/3 leg swelling. Blood investigations are within normal limit. Now I have a question to the audience. What could be the differentials with this clinical picture? Any guess?
It seems to be a case of soft tissue sarcoma, since it is rapidly growing and painless, painful, and the surface is again irregular surface. Significant loss of weight also. So this case of seems to be a case of sarcoma, soft tissue sarcoma.
Thank you, sir. Maybe soft tissue sarcoma, but important finding is adherent to the bone and non-mobile, gradually progressive. Maybe some other. Okay. The next question is what we should next prescribe the investigation. For a bone tumor, bone swelling, 17-year-old male swelling, the next investigation, X-ray, CT or MRI. The question from the audience. So general consensus is for the X-ray because the basic investigation and gives a useful finding. X-ray chest also, okay, sir. Now we prescribed we have an X-ray of the leg bones along with clinical picture. Any guess for the diagnosis now? According these points, bone versus soft tissue swelling. How many will say is it a bone swelling?
Looking to the age, looking to the age, 17 years old male, and diaphragm involvement, and there is a destruction of the bone in the middle and lower one-third junction, upper one-third and middle one-third junction, and there is a periosteal reaction, and that looks to be a speculation type.
Okay, sir.
So it would be a Ewing sarcoma.
Sir, we will discuss later whether it is a benign or malignant. Malignant tumor, bone origin.
Yeah.
Any other guess? Sir, what about primary and secondary?
Primary.
Okay. So we will discuss according to the clinical picture and the X-ray finding. According to the age, if you describe, we have 7 differentials according to this age. These are Langerhans cell histiocytosis, osteomyelitis, fibrous dysplasia, osteosarcoma, Ewing's tumor, and the leukemia according to the age. But if we see the site of the bone, we may divide the bone in epiphysis, diaphysis, and metaphysis. And in the diaphysis swelling, we may have potential 5 diagnoses that are Ewing sarcoma, fibrous dysplasia, osteoma, osteoblastoma, and lymphoma. Next, if we see the margin of the tumor, we have usually 3 types of the margin. One is well-defined, sharp sclerotic, that usually occur in the benign tumors. And next is sharp lytic, but without sclerotic border, that is little bit aggressive tumor. And in the malignant aggressive tumor, there is ill-defined margin. In this clinical picture and the X-ray, we have ill-defined margin that shows it's a malignant or aggressive lesion. And according to the diphageal location and the age, the potential diagnoses are osteogenic sarcoma, Ewing sarcoma, and lymphoma. The next is type of the bone destruction. Geographic destruction usually occur in the benign. Moth-eaten occur in myeloid tumors, while permittive are characterized by ill-defined, very small over radiolucency and lucent streaks, and these occur usually in the Ewing sarcoma, osteogenic sarcoma, lymphoma. Very rapidly progressive tumor causes permittive type of the bone destruction. Next, the periosteal reaction. Bone neoplasm elicits periosteal reaction that can be categorized as uninterrupted, usually occur in benign, interrupted in aggressive tumor. In this clinical picture and the X-ray, we have aggressive type of interrupted periosteal reaction, and in the X-ray, this is the Codman triangle, which shows the elevation of the periosteum by the rapidly aggressive growing tumor. So we have diagnosis of osteogenic sarcoma, and maybe sometimes rapidly progressive Ewing sarcoma also causes this type of the periosteal reaction. Matrix presentation, the tumor have specific matrix. If it is osteogenic sarcoma, then cloud-like osteoid is present, while on the right side there is a punctate popcorn-like calcification significance of chondrogenic tumors. Now these are the pictures and findings of the X-ray. We have left tibial diaphysis and a poorly defined margin, permittive bone destruction along with interrupted periosteal reaction, matrix is osteoid and soft tissue mass present. With these findings, we have differentials for tumor, and the first differential may be osteogenic sarcoma and very near about the Ewing sarcoma. With these 2 differentials, we now went for the radiological discussion for MRI finding.
Good morning to all. So the MRI of the leg of the patient was advised for further evaluation. So there are T1 sagittal, T2 axial fat set images, T2 spare axial and T2 spare coronal as well as sagittal images. We can see there is altered marrow signal intensity lesion in the middle part of the shaft of the tibia with large soft tissue component along the anterior and anteromedial aspect. We can see some sunburst type of reaction, periosteal reaction also here. There is no involvement of the knee joint, and there is no extension of the soft tissue component in the posterior compartment and interosseous compartment to involve the major neurovascular bundles. So, our two top differential diagnoses are osteogenic sarcoma and Ewing sarcoma, but on the basis of findings on the X-ray, the possibility of osteogenic sarcoma is most likely. However, histopathological correlation was suggested for further evaluation. This is the report patient was carrying with him. CCT chest and abdomen was done to rule out any metastasis in the chest and abdomen, and there was no metastasis in the chest and abdomen. Now I am inviting Dr. Ankit Godara for further discussion.
Thank you, sir. So once the radiologist suggested to go for histopathological correlation, we had posted the patient for a Siam-guided Jain needle biopsy under local anesthesia with all aseptic precaution. And with the help of Jain needle, 3 1 centimeter slices were obtained and sent in 10% formalin for histopathological evaluation. I request Dr. Astha to come and discuss the pathological side of the case.
Good afternoon, everyone. So I'll be discussing about the histopathological assessment of the patient. This is a 4x view, and in this 4x view, what we can see is in the upper segment, we are having in the upper part of the slide, what we are having is all hemorrhage. What we are having in the upper segment is all hemorrhage, and below there is a cellular tissue fragment. When we move forward, this is the view of the cellular tissue fragment which we saw previously. And in this, what we can see is there are discrete cells, and these are the tumor cells. They are all large, they are pleomorphic, that means they have different shapes and sizes, and they are having hyperchromatic nuclei. All these features point toward a malignant entity. This is a 40x view, but this is a separate focus. What we can see here is there is a newly formed osteoid, and this osteoid here is depicted with the help of an asterisk. And in the vicinity, there are tumor cells present. These tumor cells are producing this osteoid, as opposed to the non-neoplastic osteoid, which we can see in the right lower quadrant. This osteoid is hyaline, it is lacy, and it is more of eosinophilic in texture. So all these histomorphological findings are in the favor of osteogenic sarcoma, which is a malignant bone-forming tumor. Thank you. Over to Dr. Ankit.
So once the diagnosis of malignancy was established, the tumor board was formed, and based on the recommendation of tumor board, a limb preservation surgery was recommended, and the case was referred to radiation oncology department for neoadjuvant chemotherapy. I request Dr. Harsha to discuss the pre-adjuvant chemotherapy of the case.
Good morning, everyone. Good afternoon, everyone. So the patient was referred to our department for the neoadjuvant chemotherapy protocol. And after the normal routine investigations and the 2D echo finding, we planned the patient with 3 cycles of chemotherapy. And the regimen used was injection doxorubicin with 25 mg per meter square dose given from day 1 to day 3 in IV infusion, and injection cisplatin 100 mg per meter square in 3 divided doses for 3 days in IV infusion. and this was repeated every 3 weeks. And at the end of the third cycle of the neoadjuvant chemotherapy, the patient was referred back to the ortho-oncology for the assessment of the limb preservation surgery. So I would like to emphasize the importance of neoadjuvant chemotherapy over here is that it has improved surgical outcomes, as the neoadjuvant chemotherapy can shrink the tumor and hence facilitating the limb sparing surgery. It has the potential of micrometastasis control while the patient is waiting for the surgery, and it is a very good prognostic indicator as well, as a good response to the neoadjuvant chemotherapy often predicts a better long-term prognosis, and along with the chemotherapy overall has a good survival outcomes. So these are the two X-rays, the pre-chemo and post-chemo. By comparison, we can see that there is a soft tissue component reduction in the post-chemo after the third cycle of the post-chemo X-ray. And also there is the enhanced sclerosis of the medullary component of the lesion. So I would like to call upon the stage Dr. Simran Thareja for anesthesia.
Good afternoon, everyone. I, on behalf of my department, would like to discuss the anesthetic challenges for orthopedic oncologic surgeries. So in preoperative concerns, first, apart from the routine investigations, we'll try to identify and optimize side effects of chemotherapy and radiotherapy that patient has taken. So the routine investigations will rule out nephrotoxicity, hepatotoxicity, any myelosuppression, if any, and the target hemoglobin should be 12 grams per deciliter in females and 13 grams per deciliter in males. And platelet should be at least 1 lakh. And apart from that, baseline ECG is done so as to rule out any cardiac arrhythmias, and 2D echo was done to rule out cardiomyopathy and diastolic dysfunction. Other than that, autologous blood donations were advised if the patient had normal hemoglobin. Other than that, as the cancer patients are already in distress and depressed state, they are counseled regarding the intraoperative anesthetic procedure they have been given, and post-op pain management techniques we give. So, next concern is we have to optimize nutritional status of the patient. So if BMI is less than 18.5 and serum albumin level is less than 3.5, so a nutritional consult is taken so as to optimize the post-op recovery. Intraoperatively, as the patient of oncologic surgeries is already on chemotherapy, so IV access is difficult. So sometimes peripheral IV access is not possible, so we can consider taking central venous cannulation. And according to the extensiveness of the surgery, if large volume fluid volume shift is there and patient has a cardiac comorbidity, then invasive monitoring can be considered. And as this surgery is of longer duration, so our first concern is to anesthetize the patient for the similar longer duration of time. So our anesthesia choice is combined spinal epidural. So it is a type of neuralgial block. So in this, we give spinal block in subarachnoid space and place epidural catheter in the epidural space so that we can prolong the duration of surgery by giving multiple doses of drugs via the catheter. And if the neuralgial block is contraindicated, then we can go for general anesthesia with peripheral nerve blocks. In this patient, as there were no contraindications present, so we preferred combined spinal epidural approach. Other concerns are if, as the surgery is a longer duration surgery, the patient might go for hypothermia intraoperatively. So perioperative temperature monitoring was done, and it was prevented using warm IV fluids, forced air warming blankets heated under padding, and optimum temperature of OT was kept at least 21 degrees Celsius, not below that. And the longer surgeries of the patient can also predispose them for nerve injuries, so the positioning was done appropriately with well padding of pressure points. Another concern is bleeding. So it was managed with use of autologous blood donations, acute normovolemic hemodilution, giving antifibrinolytic agents like tranexamic acid, or we can give dexmedetomidine to decrease the mean arterial pressure so as to further reduce the bleeding. And also, if the reason of coagulopathy is to be known, then we can use thromboelastography and rotational thromboelastometry so as to go to have goal-directed control of bleeding. For adequate hydration, we use holiday cigar formula for the fluid management. And another concern is tourniquet syndrome, as tourniquet are used in the surgery for bloodless feel. When the tourniquet are inflated, it should be inflated for a maximum period of 2 hours, and after 2 hours, 10-minute deflation interval should be there. If it exceeds, then the deflation of the tourniquet can cause release of anaerobic metabolites into the circulation, causing hypertension, metabolic acidosis, hyperkalemia, myoglobinemia, and possible renal failure. Then the next concern intraoperatively is bone cement implantation syndrome. But in this case, bone cement was not used, so this was not the concern in this case. Postoperatively, our main goal is to achieve postoperative analgesic period, pain-free period to the patient. So for that, we use multimodal approaches, and this different class of drugs are used which inhibit the pain pathway at different level. So first is epidural top-up, as we have given combined spinal epidural to the patient. So we give epidural top-ups every 8 hourly to the patient for last 3 days. Then other than epidural top-up, IV opioids, IV paracetamol, low-dose ketamine, and transdermal patches can be used. And another concern is deep vein thrombosis. It can be prevented if the surgery site permits. Then we can use mechanical thromboprophylaxis. Other than that, pharmacological prophylaxis can be used. And another concerns are early physiotherapy and postoperative nausea vomiting. Thank you. Now I will hand over the mic to Dr. Rajkumar sir. So the factors that negatively affect immune system can cause cancer recurrence. So we have tried to decrease these factors: patient anxiety, hypothermia, allogenic blood transfusion, perioperative malnutrition, and pain. So at last, surgeons and anesthesiologists should communicate prior to the surgery, as it allows anesthesiologists to appreciate the fineness of every step and to plan according to the surgery. So moving on to the next slide.
Thank you, Simran, for detailed investigation and rule out all the possible complications in our patient. After the neoadjuvant chemotherapy and PAC, the patient was with us, and limb preservation surgery has changed from being an exception to a standard practice in the management of primary malignant bone tumors. It improves functional outcomes without sacrificing local disease control, as long as complete tumor resection is anatomically possible. Limb salvage surgery involves wide resection of the bone tumor followed by reconstruction of the defect. The challenge in reconstruction defect is more. We have two options. One is endoprosthetic reconstruction, other one is biological methods. In endoprosthetic reconstruction, also it's easy. We have a ready-made prosthesis. Any type of any length of the bone segment can be replaced easily with these prostheses, and the functional outcome are excellent. But they have high financial cost, sometimes from 5 lakh to 20 lakhs. 12% deep infection rate, that is too high, and loosening and breakage is the rule. 70% probability of the further surgical procedure within less than 10 years, and sometimes amputation, and it is almost up to the 25%. While the biological reconstruction method, if we take autograft for filling the defect, they have their limitation, like limited quantity, side mesh graft not possible, and second surgery related morbidity to the donor side. And allograft have their own complications like high cost, transmission of viral diseases, high infection rate, difficult to get size specific graft, fracture, graft rejection, and late incorporation. That's why next is distraction osteogenesis. It forms a new bone by distraction of the callus, and commonly known as Ilijaro method, but it takes a longer time to grow the bone, and pin tract infection are common with a patient on chemotherapy and immunocompromised, and needs some multiple revisions. So, recycling and reimplantation is being commonly proceeded. Here, the bone is treated, caused disease-freed, and then reimplanted in the host bone. And we have two methods: frozen autograft with liquid nitrogen and extracorporeal irradiation and reimplantation. In frozen autograft with liquid nitrogen, we excise the tumor mass, and emerge into the liquid nitrogen at minus 195 degrees centigrade for 20 minutes. Then we remove it and reimplant into the host bed. This is the example. On the left side, a resected part. In the mid side, treating with the liquid nitrogen, and on the right side, this is treated tumor part of the bone and reimplantation in it. And we proudly say our institute was the first to incorporate this technique in bone tumors in North India. And still only the few centers in India uses this technique, and we are one of them. But they have their own disadvantage. Although advantage of fusion graft are many, they have simple procedure. In a OT setup, we do not need an radiotherapy or an other department collaboration, superior osteoconductive, osteoinductive capacity, but they are not for the longer segments. When you have to remove a larger segment of the bone, the quality little bit inferior in this. And one major complication is when the vascularization occur in the bony segments, it becomes weakened, and sometimes pathological fracture are more in it than the ECRT. That's why we used ECRT in this patient, because it provided good quality autograft along with other benefits. For the ECRT, we did a surgical planning. On the MRIs, the tumor length was 10 centimeters, so the margin was taken 4 centimeters above and below. So total length of resection piece was planned 18 centimeters. In the OT, this is a picture of OT where an incision lines has been marked. Tumor skin flaps were raised, tumor margins were identified, again checked under the C-arm in the OT, and bone piece was resected. After the tumor excision, a sample of marrow was taken for the frozen section. And after the resection of the piece, under full aseptic precaution, the resected piece is then transferred to a separate trolley. This is separate trolley. All the soft tissue, including the periosteum and the gross tumor tissue, was stripped off from the bone. All pathological growth was sawed off from the normal contour of the excised tibia and tried to make the anatomical fitting of this piece. The picture showing cleaning of the resected piece. Medullary canal was cleaned with the sequential hand reamers. After that, after this, the bone specimen was washed with the normal saline and hydrogen peroxide and mopped with vancomycin soaked gauges to prevent the infection. The bone segment was tightly wrapped in sterile polyethylene surgical wraps in 2 separate layers and placed in a sterile container. All precaution was taken to prevent air bubbling within these layers. This video is showing the cleaning of bone segment and wrapping with the normal saline and vancomycin soaked gauges. After this, the tumor was placed in a sterile container. One of our residents kept this bone segment into the sterile container, and container was transported from Gangori Hospital, Pandit Deen Dayal Upadhyay Hospital, to the SMS in ambulance. One additional ambulance was also kept in case of any breakdown, and it was protected by the police also. And we were very thankful to the hospital administration, Dr. Ajay Mathur, the superintendent of Gangori Hospital at that time, and the police administration and general administration. We were able to send it this resected piece to the SMS within 3 minutes, and total distance was 3 kilometers.
Use green corridor.
Yeah, and use the green corridor for this. Now the resected segment has been sent to the radiation oncology department. Now I invite Dr. Harshayan Mehta to proceed further.
Thank you, sir. So the resected specimen was sent to our department for the extracorporeal irradiation. So this is the technique. Extracorporeal irradiation is the technique of radiation treatment in which the resected involved segment of the bone is, after taking out of the body, is treated with a radiation therapy in isolation with the rest of the healthy body tissue. So which helps in reducing with a very high doses. So the residual tumors can be killed, high potential of killing the residual tumors, and with the advantage of the lower recurrence rates. Also, since the normal healthy tissue is not involved in the radiation treatment, so the radiation injury is to the uninvolved bone segment or the soft tissues or the joints and the rest of the healthy bodies is avoided, completely avoided. In the extracorporeal irradiation, what we did was the double-layered draped specimen, which was wrapped in another layer of the green sterile drape, was kept in a standard transparent plastic box and was treated with the parallel opposed anterior-posterior and the posterior-anterior fields. It was done with the SAD technique, that is source to axis distance technique, with the ISO center at the midpoint of the draped specimen, which is kept in the transparent box. The field size was covering the entire specimen, and the dose used was 50 gray in the single fraction, that is 25 gray from the anterior-posterior and 25 gray from the posterior-anterior field in the single setting. The whole treatment irradiation time for this patient was around half an hour. So this is the image of the specimen being irradiated. After the irradiation of the specimen, it was sent back to the operation theatre as early as possible for the completion of the biological reconstruction. So this is the treatment planning image in which the mid-plane dose of 50 gray in single fraction using the SAD technique was given with the parallel opposed beams. Now I would like to call upon the stage Dr. Harshwal sir for continuing.
Thank you, Dr. Harsha, for quickly irradiating our resected specimen. The time duration was, it took 3 minutes to travel 3 kilometers from Pandit Deendayal Upadhyay Hospital to the SMS Hospital, and 20 minutes was taken at the Radiation Oncology Department for extracorporeal irradiation, and then back within 4 minutes, it was sent back to the hospital, Pandit Deendayal Hospital, and total traveling time was only 28 minutes in this whole duration. It was really meticulous planning by Dr. Ajay Mathur, the then superintendent, our head of department, Dr. Sudhir Yadav sir also, Dr. Pankaj Jain, and all anesthesia department that is present in OT also, Dr. Sunil Chauhan sir, Mamta Khandelwal madam, Dr. Harsh. So during the ECI time, the graft bed was tumor bed was also prepared. The fibula was resected and attached to the proximal part of the tibia, and the implantation procedure was proceed. And during that period, the temporary fixation by the plates was also done, so that time can be minimized in this surgery while the ECI process was done at the SMS. We were prepared to get the graft and immediately plant it here. So this is the picture of the irradiated segment which we got after the irradiation. It is ivory white, devoid of all viable healthy tissue, and it has been proved in histopathological also that 50 centigrade dose is sufficient to kill any viable tissue in this bony segment. We prepared the resected specimen with filling of iliac crest into the medullary cavity and reimplanted back into the host. And irradiated tibia was reimplanted with 2 locking plates, each on medial and lateral side. Hardware was covered with muscular envelope and wound was closed nicely without any plastic surgery intervention.
So after the completion of the surgery, patient was referred to our department for the adjuvant chemotherapy protocol, and patient, after assessment of all the routine investigations and after them being normal and the surgical site wound healing and absence of any surgical complications, we planned for the 3 cycles of the chemotherapy, which was this regimen used was similar to the regimen used in the neoadjuvant setting. And yes, I would now like to call upon Dr. Harshwal sir.
In the follow-up, the follow-up was uneventful. Suture removed was done at 2 weeks. Knee mobilization started at the 2 week, and partial weight bearing was started at the 6 week, but the full weight bearing was delayed according to the clinical and radiological process, and it was 7 months when we started the full weight bearing on the limb. This is the follow-up picture at the 6 month, 5 year, and the 9 years. The implant is still well seated. Our irradiated segment is well incorporated into the host bone, and this is the good healing of skin margins and with a minimum scar. This is the functional results of our patient, and the picture was taken day before tomorrow, just 2 days back, and he's able to do all his normal activities, full range of motion at the knee, ankle, and hip joint, and he can bear all body weight on this limb. And this is the functional results of the patient. And one more, I would like to introduce our patient also, who is standing in this OT. Jayaprakash, please. He is the patient here. The 9-year post follow-up. Better. Jayaprakash. So is the great examples of our technique of irradiation as well as the incorporation of all specialties and multidisciplinary approach, what we can change in a patient's life in a good way. So the conclusion is the case of a 17-year-old male diagnosed with osteogenic sarcoma of the left diaphyseal tibia who underwent a comprehensive treatment regimen involving neoadjuvant chemotherapy, wide excision, extracorporeal irradiation, and reimplantation adjuvant chemotherapy, culminating in a remarkable 9-year follow-up with outstanding functional outcomes, represents an exemplar of innovative clinical management. So the take-home message is extracorporeal irradiation is a useful, convenient technique for limb salvage in diaphyseal sarcomas. It is oncologically safe, provides an anatomically sized mesh graft for biological reconstruction, cost-effective as compared to the prosthetic device. The limitation of the procedure are it is not applicable in tumor bones which are structurally weak and in bones with pathological fracture, but it is a highly technical procedure and the best result can be obtained in structured musculoskeletal oncology services where multidisciplinary services are available like our institute. Now the question is, why did we select this case? Because of this unicity. This case is of osteogenic sarcoma. The incidence is 1:1 million case in a general population, and we had diphyseal osteosarcoma that is still rare, rarest of the rare, and 10% of all osteogenic sarcoma comprises diphyseal. And in that 10% cases, we need to find out which bone has not been destroyed by the tumor tissue also. So the correct timing when the patient approach to the hospital is also important. We had long follow-up. We are thankful to this cooperative patient. He is always available for us. Whenever I think that where is my patient, I call him. He is always available on the phone. Every time he comes at my clinic, give a good X-rays and a clinical picture. I have presented him in various conferences also. And multidisciplinary approach, which is the strength of our institute. And proudly say that this was the first case of the state which was treated with extracorporeal irradiation and reimplantation. And second, this was the only case of orthopedic oncology which was treated with a green corridor between the two segments, and we thought about the life of a patient. If a general public population can get this type of the VIP treatment also. But the last, not the least, but the most, our team leader, Dr. Sudhir Yadav sir, who is not with us, but he is beloved Sudhir Yadav sir will always remain in our memory. He was the team leader in this whole scenario, in this whole picture. We always remember the sir for this greatness. He always provide the full freedom to think and take new innovations in our surgery. Along with, I am thankful to the team also. Dr. Pankaj Jain sir is always standing with me, and the anesthesia team, Dr. Sunil Chauhan, Harsh Bose, and Mamta Khandelwal madam. Please raise your hand if you are here. And this was the appreciation letter given by the patient's relative to the Dr. Great Sudhir Yadav sir. And this appreciation letter was framed and still it is hanging on the walls of Gangori Hospital Operation Theatre, and that remembers the greatness of the sir. Thank you, sir. These are the references, and thank you.
So today's CPC was really engrossing, and we have the teacher of today, that is the patient himself, is here. So I would like to ask our dignitaries, our beloved principal sir, our vice chancellor sir, our convener sir, and co-convener ma'am, and our HOD of orthopedics department to felicitate this patient. Audience, please clap. Now I request Monica ma'am to present the vote of thanks.
So good afternoon, everybody. It was indeed a very beautiful presented CPC, and we were actually, I was totally amazed. I could never believe it. A bone can be taken out and reimplanted after irradiation, and it was such a successful surgery. And it has proved that multidisciplinary approach is the key of success for every patient, I would say. Especially it was true for this patient. I'm so much thankful for our newly appointed principal, sir, Dr. Deepak Maheshwari, sir, to come here and sit by us. It is always very encouraging to see our team leader sitting here. I'm immensely thankful to VC sir who has taken all the time, Dr. Dhananjay Agarwal sir, Honorable VC sir, to come here and encourage all of us. I'm also thankful to MS sir, Dr. Sushil Bhati sir, to come here, and we were very happy to greet all of you as our new team leaders at various platforms. And I'm also thankful to all the audience who have come here, because without audience, any of the CPCs will not appear to be fruitful, even if it is the best of CPC. I would also request now from this platform to make this activity a mandatory activity from this time, and especially for SRs, we are giving SRs the opportunity to work in this premier institute, but they should not forget academics is also very important. So they should also have a SR appraisal form, which we have already made, and made the entry possible in their logbooks or in the SR appraisal form. Similarly, it's true for the postgraduate also. You have to put a case summary report, whatever case has been presented in CPC, put it into logbook in form of a summary, and made the signature by your guide or respective HOD. So with this, I thank you all, and of course the very effective CPC team, all my buddy members, they are doing an excellent job, and thank you. The next, please, one more request. I'm literally struggling through making the circular come through medical education unit. So the next department is anyone from dermatology? So we'll convey this, but the circular should be prepared at least 1 week before everything has to be done. So you have to select your case, you have to give me the required details so that the circular can be taken out from the MU. So this I have already shared in the WhatsApp group also. That circular notice I'll be sending to the head of the department, Dr. Deepak Maheshwari sir, and I hope this time at least 10 days before it will be done. Thank you all for patient listening, and a cup of tea with samosa is waiting outside for all of you. Thank you.